Okay, so now we are going to look at plan characteristics file, which is another data source to supplement PDE data. Let's see. Right, so before I start, one note here is for the earlier years of data between 2006 and 2014, this plan characteristics file included information related only to Part D. And then since 2015, they changed this plan characteristics file to include information on Part C plans, Medicare Advantage plans. So you can now have, when you purchase, you have to separately buy these plan characteristics files. So you will have information on both the Part C and Part D plans. But if you are still interested, I'm interested in only Part D plans, then there is an indicator, Part CD indicator. So Part C, PTCD, Part C, the indicator equals 2 is Part D only plans. So you can select those plans. So what is a plan characteristics file? A plan characteristics file contains information about Part D drug plan type, benefit design, and premium and cost sharing information and service areas. So then when do you wanna actually purchase a plan characteristics file? And you have to, I think you can buy, but if you wanna get the plan ID, you will probably have to justify in PDE data. So if you are interested in the patient characteristics in each plan type, whether who are in HMOs versus who are in PPOs or who are in MAPDs versus who are in PDPs, you can use this part, the plan characteristics file, and you can see the plan type. And also anything that we have discussed so far, medication utilization or cost, and do they vary by plan type or benefit scheme? If Part D plan provides more generous benefits, do they have increased medication utilization or do they spend more? So you can do all the analysis by plan type and benefit scheme or service areas as well. If you want to draw some national map and how much they spend, right? And also if you are more interested in sorry, right. So if you're interested in, okay, so how beneficiaries choose Part D plans, what kind of a plan characteristics influence beneficiaries' choice of a Part D plans? Is this premium or is this a benefit? So if you are familiar or if you're interested, you can actually develop some plan choice model using Part D plan characteristics file. And also in my case, most of the time I do buy a plan characteristic file, even though I don't have a specific interest, I always include types or some other characteristics as covariates in my regression model. And that's oftentimes it's my justification. And of course, you have to link a plan file to MBSF and PDE files. Now, one thing about plan characteristic file is that you will see 6 different sub-files when you buy a plan characteristics file. I mean, it used to be 5 sub-files between 2007 and 2014, but now it's a 5 sub-files. It's now 6 sub-files. It's a plan benefit base file and premium file, cost sharing tier file, and service area file, and crosswalk file, and special need plan contract files. Oftentimes, if you are simply interested in plan type and benefit design, that's all in this benefit-based file. When you use these sub-files or plan characteristics file, please pay attention to the unit of record. The linking variables or merging variables, it really changes by sub-files, whether you need to do one-to-one merge or one-to-many merge, or sometimes many-to-many merge. And you pay attention. Otherwise, the data will probably look odd when you get afterwards, when you get some numbers, right? So the first, let's look at what's in the benefit base file. So base file includes plan type and drug benefit information. So here, the one record represent contract plan. So we've been using this term a lot, contract and plan, and what is this and what's the difference? So contract refers to an organization that enters a contract with the CMS. right? So for example, United Healthcare in Minnesota, they want to say, oh, I'm going to provide the Part D the benefits. So they enter contracts with the CMS and they get assigned this number, let's say H0000. So that's their contract ID, and could be Aetna serving Virginia, or Blue Cross Blue Shield serving Philadelphia, not Philadelphia, probably Pennsylvania or some areas, and they all get this specific contract ID. Now, once they get assigned this contract ID, they can develop or they can offer different products. Here, product means a specific benefit package. So, for example, you could begin with, oh, okay, I'm going to develop policy or benefit package that has a really standard Part D benefit, beginning with the deductibles, and some co-insurance, 25% co-insurance, and then gap and catastrophic coverage. There could be one product. And then they get assigned this number, plan ID 001. And then they are thinking, well, a lot of beneficiaries don't like deductibles. I want to develop new type of benefit package. So the Part D plans are able to modify benefit schemes. So they remove deductibles and they remove co-insurance and they just replaced with a co-payment benefit scheme. Then, okay, so this is a different product. Some beneficiaries may like it. So that's 002. So within contract ID, there are several plan IDs. So here for contract ID, we've discussed this in the morning. So the first letter of contract ID indicates organization type, which we saw already earlier. So here H is a local, but H is a little bit tricky because H include both local managed care organizations as well as some unique other types of plans such as demonstration plans or national PACE or cost plans. And these plans are, unless you are specifically interested in this type of plans, we usually don't analyze these plans, but their contract ID starts with H as well. So now you can see that just using the first letter of a contract ID, you may not be able to select the plans that you want, only those plans that you want. So you will have to combine with other information. So here, cover this. R is regional PPOs, and S is a standalone PDPs, and E is this. I said here, employer direct contract. So this is a very small segment, and there are another type of employer-sponsored plans. It's different from employer direct contract plans, which we'll cover pretty soon. Right. So now here you can see that now the numbers of plans should be always greater than or equal to number of contracts when you select this first digit of contract IDs. So we have only 3 employer direct contract plans, and the number of plans is 4. Now then, how can we actually select only local managed care plans, MAPDs? If you want to exclude this unique type of plans like a demo or a PACE or cost plans, so you have to use some other information, which is here. These are all different variables included in base file. There is a variable called organization type. I think it's org type, variable name is org type, and it tells you whether plan is the org type is contract level information, whether the contract is a local MA plan or regional PPO or standalone PDP or employer direct contracts. So there was a question, how can we where can you get the information on MAPD versus standalone PDP? And this is one thing that one variable you can use. So local MA plans and regional PPOs are MAPDs, and PDP is a standalone PDPs, and others are some specific or special types of MA Part D contracts. And for plan type, okay, so now I know that which whether this organization is a local MA or regional PPOs, but these local MA plans, they could be HMOs or they could be PPOs. Can I know? Yes, that's in the plan type variable. So plan type, you can get more the detailed information about plan type, whether it's HMO or local PPOs or private people service plans. Private people service plan is also one of MAPD plans, not traditional people service coverage, right? Okay. And also there is a variable called the demo type. So demo type, usually we use this to exclude any contracts that are demonstration project that offer demonstration coverage. Or if you are really interested in, oh, my interest is in ASRD demo project, then you could use this variable to select only those contracts or plans. And now you can see here, there is one variable called, we call it EGWIP, it's Employer Group Wave Plan. Oh, EGWP. How is this different from employer direct plans, right? So that's coming in the next slide. And then also we have a variable called the special need plan SMP type. And I think Becky is going to cover in the next section. So what is this EGWIP or employer group wave plan? So EGWIP with this variable indicates employer sponsored Part D plans. So these EGWIPs do not have any benefit or tier information. So if you are interested in benefit of the relation between benefit schemes and drug utilization, you cannot analyze EGWIPs. And also some EGWIPs may not actually supply PDE data, and they have a somewhat different reporting or data submission requirements. And here what I want to say is that not all EGWIPs are employer direct contract plans. So if you create a 2x2 table here, okay, so it's 3x2 table, right? So here, EGWIP, this is indicator, whether this is EGWIP plan or not, yes or no. And then you want to see, okay, what organization type these EGWIP plans are. You can see here only 4. Oh, we saw that there were only 4 employer direct contract for plans, right, within this employer direct contract like this. So, oh, yes, it's only 4. Now, this EGWIP equals yes, and you see a lot of standalone PDPs and a lot of MAPDs. Oh, these plans, 254 EGWIPs will have a contract ID starting with S. 1,467 EGWIPs will have a contract ID starting with H, right? So when we say that, oh, I'm going to exclude employer-sponsored plans, you have to use EGWIP indicator. Not just, you cannot simply rely on employer direct contracts. And so I'm going to tell you what's going on here and why. And so here is, let's suppose University of Minnesota, they decide to provide a Part D plan coverage to their, the older employees or retirees. So one way they could do is that they can enter a contract with the CMS directory. So that's direct contract. I'm an employer, but for my employees, to provide the Part D coverage, I'm entering contract with CMS. Then they get assigned the contract number starting with the E000. Now, if you think about it, the mission or the aim of this organization, University of Minnesota, is not providing Part D plans. It's not insurance company, right? It's just some benefits for their employees. So it's just too much work to set up this contracts with the CMS and going through all the work. And then they think about it and they see that they have in the next their neighbor, there's a United Health. And United Health already has contract with the CMS to provide a Part D coverage. So they get assigned, they have this contract ID starting with the H000. So this employer or University of Minnesota, they contact United Health and say that, hey, could you create one product or one benefit package, or you can say one policy only for our employees? So separate those, this one benefit package from other benefit package, and just that only our employers can sign up for that. Then United said, sure, why not? Then they get assigned. So contract ID is already H, and then their plan benefit ID will become 800 or 801. It's usually it's starting with 8. That's another way to actually you can tell from any public source data, looking at plan ID, if it starts with 8, that's employer group waiver plan, even though contract ID starts with H or S. So that's EGWIPS, and we call as employer sponsor plans, not employer direct contract. So if you use this EGWIP indicator, you can capture all employer direct contract plans. But most EGWIPs are MAPDs or standalone PDPs, starting with the contract ID starting with the HRS. So please use this indicator. It's often forgotten, or not many people actually pay attention to this variable, but it's a somewhat important variable to analysis using any plan information. So why do we actually emphasize or just mentioning this? So when you get actually PDE data and then plan characteristics file, when you begin to create some numbers, right? And then you want to actually get, oh, am I on the right track? Or even my data, the data that I received from CCW or something, is this really correct? And you want to check. So one way you can check is getting some this real simple descriptive data and compare them with public some information, right? So every year, MedPAC or Kaiser Family Foundation or Commonwealth, they provide how many party plans are available and how many PDPs or how many MAPDs. And you can actually see, oh, okay, do I have the complete data? Am I doing correct, right? So you get the 2021 party data, including PD and plan characteristics file, and then you begin to create some tables, like numbers. Now it's time to really pay attention to footnote of those tables published on the web or in the public data, public resources. Now, almost always, it says that this table excludes PACE demonstration and cost plans and employer-sponsored plans, not employer direct plans, employer-sponsored plans or LINET or SMP or Part B only plans. Now, in order to do Apple and Apple comparison, you have to exclude these as well. And this is time that you use those indicators or variables. There is also indicator that tells you about whether this is a Part B only plan or LINET or SMP or cost or employer sponsored plan. And please use EGWIP indicator, not just looking into employer direct plans. So here you have to use both contract and plan specific information. So we're going to look into this a little bit more. You can actually see the plan characteristics file in the exercise, and in the Excel file you can actually select and how the numbers changes, and you can see yourself. Now, and then what's in the base file, there is a plan benefit information, right? So benefit information is they provide 4 categories, and I sometimes actually put the first 3 groups together into one category because these are all same value as standard benefits. So the first value, define the standard, means that this plan offers really the initial standard benefit scheme that has deductibles and 25% co-insurance and etc. So that's define the standard. Now the second and third the categories, and these have the same value. They actually equivalent to the standard plan. However, they are a little bit deviating from this. The party plans modified the benefit scheme. So they may have a little bit lower, reduced deductibles, and so they don't like a 25% co-insurance. So instead of co-insurance, they use a co-payment, and they develop some tiered benefit structure. So those plans are in here, whether it's actuarially equivalent or basic alternative. And then the fourth category is a little bit different. So in terms of a value, this enhanced alternative provides more generous or more enhanced benefits compared with the standard benefits. So there is always additional coverage. Either just the co-payment of the dollar term is low, or the out-of-pocket the cost sharing is lower, or there is another excluded drugs. You saw that the non-covered drugs in the earlier section. So non-covered means that non-covered by Medicare Part D, by standard plans, but those are actually covered by this enhanced Part D plans. So even though Medicare says that we are not going to cover that drug. Part D plans specifically, they can provide a more generous coverage, covering those excluded drugs, or even maybe they are providing coverage for OTC drugs. So those are all in this enhanced alternatives. So here's separately by the MAPD versus PDPs, and you can see how many plans or a percentage of plans are offering different types of benefits. This yellow gets actually larger, and over time. Now I was surprised here too. It's 97% of MAPDs provide enhanced coverage. So they are very generous. And even in PDPs, they cover 61.6% of PDP standalone PDPs now provide enhanced alternatives. And you can see how little, almost all, over 1%, 32 MAPDs plan provide defined standard benefits, and it's almost not, or no, here probably 32 as well. Yes, I don't see blue here, but probably 32.1% of standalone PDPs cover the defined standard benefits. Otherwise, they move on to enhanced alternatives, or they probably change the cost, the benefit scheme into more tiered co-payment schemes instead of deductibles or co-insurance. And also you can see that, well, I'm not really interested in this categorization. I just want to know whether the plan has deductibles or not. Then we have a separate variable called the deductible type. And you can see here there's a standard versus reduced or zero, no deductibles, right? That might be some of your interest as well. What happens if there is no deductible? You can see here about half of MAPDs don't have any deductibles. And for PDPs, deductibles, no deductibles, about 14% of PDPs don't have deductibles. Medicare defined amount is a lot in standalone PDPs, and MAPDs only 7.5%. In general, MAPDs provide a more generous drug coverage. If you remember, Stephanie covered in the morning, we touched briefly because they have another product line that offers Part A and B service coverage through Part C, and they can actually cross-subsidize each other. So when they have some saved revenues from Part C side by providing coverage for Part A and B services, they can actually use those extra revenues to provide a more generous Part D plans. It's called cross-subsidization. Now, and then that's actually what's in the plan benefit base file. So you can probably see if you are thinking of some research ideas or study ideas along with this line, you can say, oh, I can probably get most information I need from benefit base files. And now there is another separate sub file called cost sharing tier file. And what does this have? So this has information on tiered. So as I said, that a lot of Part D plans actually develop the benefit scheme that has different tiers and different co-payment. And of course, they could charge co-insurance for a specific tier as well. But so what is a tiered benefit or tiered benefit scheme? So this is what the plans actually create the different tiers and then place a specific type of drugs in a specific tier. For tier 1, I'm going to put only generic drugs. And tier 2, I'm going to put only branded name drug, brand name drugs and etc. And then they actually make the cost sharing vary across tiers. Right, so this is a one way actually try to manage steer their enrollees towards a specific drugs, right? So when you charge a different cost sharing for each tier, you want to put more preferred or more cheaper drugs in a preferred tier that has a low cost sharing so that their enrollees can use more of those drugs and in that tier. So here the cost, so all this and the information about cost sharing and tier is in this cost sharing tier file. And here the unit of record is contract, plan, and tier. Actually it's somewhat huge file because each plan develops probably 5 or 6 tiers. Right. So here, what information does this have? When you have this contract plan tier for each line, for that tier, oh, what type of drug is covered in the tier? Is it a brand name drug tier or a generic uh, drug tier, right? And then so, oh, what's the cost sharing type? Is this a co-payment or co-insurance? And then once it says co-payment, then what's the amount? What's the co-payment amount? Then once this says co-insurance, or what's the percent? What's co-insurance percent, right? So depending on cost sharing type, you will see either dollar term or a percentage in cost sharing amount. So for this drug type and cost sharing amount, you can also see this information by benefit phase. They may actually change this, the cost sharing or type or cost sharing amount depending on benefit phase. So all this information is available separately for pre-ICL or ICL or gap or catastrophic coverage. And also your cost sharing or your benefit scheme depends on how many days you actually fill the prescription. It's a 1 month of a supply or 3 months of a supply or other days. And also it depends on your cost sharing may depend on type of a pharmacy you use, whether the pharmacy is in network or whether it was a mail order, whether it was a preferred pharmacy or not. They may have some preferred pharmacy and non-preferred pharmacy. So all those information is in the cost sharing tier. So here's an example. Then you can think of, so do we really need this file, or how can I use this file, whether I want to use this file or not. Here's one example. You can use this cost sharing tier file. So now we know that here, so using information on drug type and cost sharing for each tier, let's see, for each plan, I'm going to simplify the information on this cost sharing information by generic versus a brand name drugs, and then the cost sharing amount for each type of drugs. So for plan A, for example, in tier 2, they had this preferred brand name drugs, and then the co-payment amount for 1 month. And just to pick only 1 month of in-network pharmacy during pre-ICL period, and it was $50. This plan B, they put this preferred brand name drugs in tier 3, and they charged $100 as co-payment for these drugs. Now I can see that, oh, wow, then is the probability of using brand name drugs differ depending on this benefit scheme between plan A and plan B? And you could guess, you could expect that, oh, enrollees in part A are more likely to use brand name drugs, right? And that's your hypothesis because they have lower lower cost sharing for branded drugs, right? So then here, so once once you look into this data, oh yeah, sure, I can do study looking into the relationship between co-payment amount and use of medications. So this is actual study. This is not final result. Which we published in a paper, but in a much more refined way we constructed the variables. But in a very simple idea, using the information in the previous slide, what you could look at is, oh, I'm going to simply take a co-payment for preferred branded drugs, and it's a continuous variable. And then your Y variable is whether the beneficiary filled this is a probably statin. Yeah, oh, yes, this is statin study. Use a statin, whether they fill the brand name statin or generic statin in 2008. And you can see here, as the co-payment for preferred brand name goes up, the odds of filling prescription with brand name drugs goes down. And this is what we expected, right? And we also looked at some other plan type. This plan type serves as a covariate. At the same time, it's interesting as well. And you can see that compared with the private fee-for-service, this is one type of MAPDs. Compared with the private fee-for-service, those who are in PPOs, preferred provider organizations, they were more likely to use brand name drugs, right? This is actual real analysis using only MAPDs, I believe. Yes, MAPD enrollees who use the statin. in 2008, and then we controlled for all other variables. So this is a one application you can do using tier or cost sharing file, right? Okay, so another thing that I want to point out here, cost sharing tier file is you may want to, depending on your interest, you may want to use this information. There is a variable called a specialty tier. This is a tier file, right? Cost sharing tier. So the unit of record is a contract plan tier, and then it has, oh, is this a specialty tier or not? So you can get a specialty, which tier is a specialty tier. So what is then specialty tier? Then you have to know what specialty drugs are. So specialty drugs are those that have monthly cost greater than $830. This is a total cost, total monthly cost, and not patient out-of-pocket spending. So monthly total cost is greater than $830, then it's called specialty drugs. So it was 830 in 2022 and 23, and it was 670 in 2021. It's a huge increase. And when I studied these things, it was only $600 in late 2010s. So part difference. So once it's defined as specialty drugs, then Part D plans can place specialty drugs in a separate tier, and they call that tier as a specialty tier. And here, once the drugs are in specialty tier, now Part D plans are allowed to charge a little bit higher cost sharing than other tiers. So up to 33%. Otherwise, usually co-insurance is 25%, but for specialty tier, you can go up to 33% as long as those increased cost sharing is offset by other benefit enhancement. In other words, by reducing your deductible amount, you can charge a higher price, higher cost sharing for specialty tier. So usually plans use, I think it's a 25%. It's pretty earlier data. I was looking at Stephanie's slide early in the morning, and it was probably between 25% to 33% co-insurance for drugs in specialty tier. But now it's somewhat tricky. So specialty tier is usually considered as, really higher cost sharing tier. But you know that some drugs are really expensive these days, right? This is really somewhat not meaningful because some drugs can cost $1,000 or tens of thousands of dollars per month. So some Part D plans, they may not create a specialty tier. However, they create something called a really non-preferred tier. I really don't want you to use drugs in this tier. And I have seen that actually it's in the data, they can actually charge up to 45% co-insurance. And I think that this is really, it's happening in 2021 as well. Now, so then you can see how many plans are using specialty tier. So when the specialty tier ID is missing, that means that they don't have a specialty tier, but only 7% of a Part D plans don't have a specialty tier, more than 90% has, and it has increased a lot over time. But since Sovaldi, it just dramatically increased up to 80 or 90%. Okay, so now that's about cost sharing tier file. Now we have another sub file called premium file. So premium file is this premium file, as the name says, it includes premium information. Yes. So here, one record represent contract, plan, and segment. So we looked at segment a little bit earlier in the morning, right? So segment here is geographic area that's covered by a particular benefit package. So you can see here, well, yes, they have the same contract ID, same plan ID. When plan ID is the same, right? That plan ID defines benefit package, which means that you have exactly the same deductibles or copayment or tier structure or co-insurance, but depending on the area, it's usually county. Depending on which county you live in, you may have a different premium. So this applies only to premium file because only premium changes by segment. So And also this segment issue is or applies only to local MAPDs. You will not see any segment ID for other types of plans. And even within our MAPDs, only 1% of MAPD records have more than one segment ID. So it's better to use a more precise information, but if you want to know the just general average premium for the plan, you can actually average the information across different segments. So that's a premium file. So we got some numbers here, some descriptive data, how much is Part D total premium is on average. You can see here PDP versus MAPD. Oh, wow. Can you see that? This is not typo. MAPDs, those plans that provide enhanced benefits, actually they charge a lower premium. That is true. And even compared with this standalone PDPs, these the relatively small number of MAPDs, they provide only basic benefits, but their premium is pretty high on average. And you can see here by deductible status. And then finally, we have a service area file. So service area file is, as the name says, you can see what areas each plan, the contract plan, right? It's a benefit package is served, is offered, right? So, and here the record is contract, plan, and service area. So this service area unit depends on plan type. So if it's a local MAPDs, local managed care organizations, their service area is defined based on county. So you will see for MAPDs, contract plan, and just a list of counties that each plan covers, serves, right? And then for if it's a regional MAPDs, so here region is we have, I believe, between 29 or 33 regions in the nation. I don't remember exactly, 33 regions maybe. So which means that sometimes one region that's a unit include several states, and sometimes one region equals one state. So that means that when this regional MAPDs, when they serve this region, that means that they cover the entire state or sometimes a multi-state, depending on how region is specified. So for this regional MAPDs, you can see contract plan and region. Region should specify state as well. You can see the state information there as well. And the standalone PDPs, and this is a state. If you have this contract plan for standalone PDPs, service area unit is a state. So you can identify how many plans are operating in each county or state or regions. So that's how Kaiser Family Foundation or MedPAC or some other agencies actually provide the tables, create the tables based on this information. Finally, okay, this plan crosswalk file. And so this tracks the changes in plan contract status as well as plan number over time. So why? What does this mean? This means that we want to identify the same contract plan over time, but they simply change in numbers. But doesn't mean because you want to see how many if you are interested in studying plan switching, you want to know, oh, this beneficiary was in plan A last year, and then how many switched. But we don't want you to identify as the same plan, but just because they have different numbers. So in this crosswalk file, you can see this has previous year information and current year information. So for this one, even though they change the plan ID as 002, if this says 001, the same contract plan, that means that they are still the same plan. And also, let's suppose some contract or a plan disappeared. They were there in 2011, but then no such contract ID and plan ID in 2012. You are wondering, oh, what's going on? Do they actually discontinued or do they change in numbers? And you can actually follow or you can track those things using this crossover file. And here you can see whether it's truly terminated, the use indicator of terminate, the termination, or it's consolidated, right? Then it's a merging because of merger and acquisition, they may actually the same contract plan. And then whether it's a new plan or it's a renewal, and for renewals, you have to really look into this, whether they change simply number or not to identify the same plan and to actually see the switching rates. Okay, that's plan crosswalk file. So again, summary that how or whether we want to use a plan characteristics file. I personally find very interesting and enjoy working with a plan characteristics file, because even as a standalone source, you don't have to buy any other data. If you buy only plan characteristics file, you still you better to have MBS file, not PDF file, but you can play a little bit more. Oh, what percentage of Part D plans have deductibles, or whether premium, how much premium differs when they offer more enhanced benefits or when they remove the deductibles. And those things are some interesting questions, and you can gauge that how much costly to cover certain, provide more enhanced benefits, right? And also you can see the geographic differences in plan availability as well as premiums, and which area do they have the highest premium or really expensive to have a party plan coverage, right? Now, so that's one. So you can use this as a standalone source. Now, if you have, most of the time, you will probably have MBSF for sure. If you have an MBSF file, you can easily create tables, this demographics of enrollees by each type. And also you can look into some factors, plan characteristics that influence beneficiaries' plan choice. And again, pay attention to identifiers or unit of record so that you can use correct merging IDs. So for MBSF file, you use a plan contract ID and plan ID. For plan base file, it should be plan base file and tier files. But if you are using premium files, you have to use the contract ID, plan ID, and segment ID. I'm not sure this should be county, not quite sure about segment ID. Service area. Yes, the service area does have a segment ID. Let me see. It should have a segment ID and service area, because segment ID represent county, different counties. Sorry, I will fix this. Okay. Now, and then now if you have a PDE files, and you can link this plan characteristics file to PDE files, and you can examine all sorts of things, cost or medication adherence and utilization or anything by plan type and benefit schemes, and also the percent of beneficiaries reaching catastrophic coverage, and whether that varies or differs by plan type or not. And for this information, again, PDE file, the record is event level. So you have to aggregate PDE level to the patient level when you construct these outcomes.
And now we're going to move on to some more plan characteristics files. These are the special needs contracts files. So I'll let Becky take it away.
Hey. Okay, great. Thanks, Steph. So the last sort of sub file for the plan characteristics suite of files is the special needs plan contract file. So first, just want to touch on the three different types of special needs plans. There are chronic condition SNPs, otherwise called C-SNPs, dual eligible SNPs. Those are for people who are enrolled in Medicare and Medicaid. And then there are institutional SNPs, and those are for individuals who are institutionalized. So the special needs contracts file lists all SNP contracts and plans, but it really just provides added details pertaining to C-SNPs and I-SNPs. This file is kind of new to me too. So when I started looking at it to prepare for the segment, I kind of, did a lot of checking. And so that's my assessment, is that the file is really pretty simple and straightforward. And, although it lists all SNP plans, it really only seems to contain additional detail on the C-SNPs and I-SNPs. So this file became available starting in 2015, and it contains indicators to show which condition categories like heart failure and diabetes, that for the chronic condition SNP plans, it's kind of like an array of 20 different condition flag variables. And that's what the file looks like for the C-SNPs. And then it also contains an I-SNP type variable, which kind of breaks out the type of institutional SNP for those SNP plans. And then it has the, contract ID and plan ID. That's how you would link to this file. Like I just said, you link to the SNPs contract file using contract ID and plan ID. Just a point of interest, SNPs are always MAPD plans. So they cover Benny's, comprehensive coverage, parts A, B, and D. The file has exactly one record per contract and plan. And in 2021, there were 971 rows or SNP plans. I did kind of validate that 971 number with the base plan characteristics base file. There's a variable in there called SNP type in the base file where you can distinguish between the 3 SNP types, the chronic condition SNPs, the dual eligible SNPs, and the institutional SNPs. Also did some verification that they're all mutually exclusive. So a D-SNP can't be both an I-SNP and a D-SNP. You're just one of those 3 categories. So the chronic condition special needs plans are plans that restrict enrollment to members with a severe disabling chronic condition. In 2021, I identified 203 of these special needs plans. And the most common condition categories that I encountered in the file for these plans were those listed here. The most common was cardio plans focusing on members who have cardiovascular disorders, chronic heart failure, and or diabetes. The second most common were special needs plans focusing on diabetes. And then the third most common was C-SNPs focusing on chronic lung disorder. Institutional SNPs are plans that restrict enrollment to those needing institutional level services. So they, like I said earlier, there is a variable in the special needs plan contracts file that will tell you a little more further detail about these I-SNPs, and that is whether or not it was an institutional plan or institutional equivalent plan. So the difference there is that institutional plans, focus on members who actually live in institutions, for example, long-term care, skilled nursing facility, or long-term care nursing facility. There are others. Whereas institutional equivalent plans can contain members that still live in the community, but require an institutional level of care. Identified using that institutional variable, I identified 172 I-SNPs in 2021. And here's kind of the distribution of this institutional type variable that I located in the in this SNP contracts plan file. You can see that the majority are all other SNPs, but for the I-SNPs, the bulk are institutional only. and followed by kind of a mix of institutional and institutional equivalent plans, with the remaining being institutional equivalent plans. So, so again, that I'm sorry that was really quick, but the file is really quite straightforward. Again, it really only provides added detail for iSNPs and CSNPs, and it's really pretty limited. Just kind of a little more descriptive about the plan type, like for the chronic condition special needs plans. It'll tell you exactly which chronic conditions are the focus of the plan. And for iSNPs, it's just the one variable that kind of tells you if it's institutional or institutional equivalent plans. Yeah, that's all I had to present on that file.